So I'm going to take you on a little bit of a journey with my professional and my personal life and how I got here today. Professionally, but it's actually been about 35 years within healthcare. Devices, diagnostics, pharmaceuticals, revenue cycle, ran a billing company for a number of years. We did back office in India. If you can't tell, it worked, who I am. And now facilities. And what's interesting about this is with all of that knowledge, I was blessed to work both on the provider side and the vendor side with different goals and initiatives. So you see this lady. Did she move yet? Did she get wheeled in? Okay, I couldn't see, sorry. So that was me about 5 years ago in 2017, except I have a little bit more of a tan. And this was one of those moments where in my career, I've been blessed to do patient journeys, speak to patients who've had cancer, look at drugs and devices from the patient perspective. And I will tell you, in 2017, I was being wheeled in for lung cancer surgery, and everything came to fruition. I remember looking up at the ceilings thinking, oh my God, they're so ugly. Is this the last thing I'm ever gonna see? And they were yellow and down, and I don't know if anyone else has gotten their eyebrows done or office, my ceilings, right? And so that's like, I started thinking about that patient journey and all the things that we assume. So here I am, my upper left lung, so if I breathe heavy, you know, I'm missing a lobe. You know, I actually launched the first non-small cell cancer drug 20 years ago, and I would have been that patient. And so thinking about the questions that I asked when we were doing the reviews, thinking about how the patient is affected, really put me in a different spot. The other thing that happened is I actually coded. And when I flatlined and I came back, I couldn't speak for about 3 months. I was intubated. And the stories that my family tells about what happened was devastating. I mean, it was just chaos in the room. And Johnson actually has something called Code Blue, and that's what led me here. So all of our experience, I'm sure each of you with your education, your personal, has led you to a lot of impact that you've made. Well, moving gears a little bit, switching into today's landscape and what we're faced with. How can we make an impact? Now, you know, I'm probably, the fourth or fifth speaker up here. We've heard a lot of repeated themes, right? Not only the patient journey, but the severe shortages, ESG, issues after COVID, increase in operating expenses. How are we dealing with this as an industry? And I'm not saying healthcare, this is just health systems. It's a very different landscape. 53% of health systems are in the red, so it's very, very challenging. But we have an opportunity. We have to look to the future for reimbursement. What can we do? How can we as a group come together and really look at creative ways? So the reason I brought up my personal experience and my professional experience was because as I laid there, I thought, I'm a total type A personality. Like I have to be in control. And if I'm not, I get anxious. And that was the first time I've ever taken Xanax just to be in that setting. And realized that if somebody gave me any kind of control in that patient room, I would have been a different person. I would have been probably doing the lights on and off, changing the temperature, doing the blinds, just because I would have had some control over my environment. So we're gonna talk about that. Coming with how that plays into ESG, another thing we've talked about this morning, right? So I'm gonna go through this quickly, but environmental, social, and governance. So ESG is something that's the Climate Pledge Agreement. I've got a couple of health systems that are part of it who have signed that. But we're talking about the planet, we're talking about the healthy buildings, and then we're talking about the patients. And those all tie together beautifully. Now, are we getting incentivized with this today? We are not, right? We're looking at ESG as a component of spending more upfront for savings, which for those of us that are in health systems or have been in health systems, how many vendors come to you and tell you how much money you're gonna save versus actually getting reimbursed, right? This is gonna help you, this is gonna help you. But we really wanna change that story. Today there are ways to get reimbursed for ESG. There's government grants, right? There's utility company rebates. We help some of our health systems get those rebates. The Green Revolving Fund is really interesting. I'm not sure if you've heard about that, but what they do is actually incentivize VP and above individuals and health systems to hit net zero or for sustainability. Obviously, donor support, which Nancy also had some donor support at the end there, and then cost savings, operational efficiencies throughout. Here are some examples of states that actually do reimburse, help technically, help financially with doing ESG goals. I would suggest that within your facilities, the director of plan operations or whoever they might be, the managers, look at the individual states because there's untapped funding mechanisms that are available today. I see a couple of cameras, I'll let it go. Okay? So, coming back to why I'm here, new pathways for reimbursement. So whether you're looking at indoor air quality, HVAC, what are ways that we can get reimbursed today? I mentioned anxiety, right? Those are different types of codes. We've known this. How does better environment benefit the patient? This is in the 1800s, Florence Nightingale came up with this, right? The environmental theory. What makes for better patient outcomes? Fresh air, pure water, drainage, etc. So why are we not capitalizing on it? How do we align our business strategies with patient outcomes? So I was talking about my professional experience, and one of them was I was president of healthcare sales for an organization called Performance Health Systems, which has their main product called PowerPlate. Now, if you like football, you'll see PowerPlate with the skins or basketball on every sideline. And I came in as a subject matter expert in healthcare. I ended up running their healthcare division then. But what we looked at was the science behind this product. How does it work? Why is it in France, they were using it for cellulite? In the US, it was introduced by the former CEO of Bally Total Fitness as a fitness product. We said in the US how it was introduced was 15 minutes on a power plate or an hour and a half in the gym. That's how it came into this country. In Germany, I remember we worked with the German government and it was used for osteoporosis, osteopenia as a prevention device. So how can one modality do all of this stuff? Well, we started with the science. How does it work? So it's called vibration therapy, so you think of this vibration belt, but it's literally standing on this device and it's involuntary muscle contraction. So we put together a medical board, a medical advisory board and scientific advisory board, and a business board. And that how are we gonna bring this to market on a global scale and how would it be received? So as you can see, we went through all the different areas from neuromuscular rehab, which dealt with Parkinson's, PT, it dealt with individuals who had cerebral palsy, MS. So that was one area. We started doing research and understanding that side of the house. We looked at fitness. We looked at sports because it initiated fast twitch muscles. So you would see quarterbacks wouldn't have to practice so much off field. They would get warm. They get warmed up a lot faster. So we went through each one of the specialties and we targeted our message. We looked at psychiatry. So we sold it to a number of psychiatrists that put it in their waiting rooms. So that when you got on a power plate prior to your session with a psychiatrist, your serotonin levels were already increased. So going in, they perceived a better visit. We looked at nephrology. People going in for dialysis would actually be on a power plate beforehand, and the uptake of minerals was faster, so you wouldn't be having to wait there for 4 hours. Endocrinology was diabetes, we looked at that, and then also pain management for fibromyalgia. This is one device that prior to us doing all of this research was just used in a fitness capacity. So here's one example for PM&R, how we looked at the codes. Now I know we need to get to codes and reimbursement, but analyzed all the codes that would work with physical therapy. PM&R is physical medicine, neurology, and rehab. PT, physical therapy. How could our providers use these codes with PowerPlate? How is it showing outcome? And I will tell you, it increased, they took out that, but hospitals, rehab facilities, and universities and colleges, you will see this everywhere. Now that you've heard of it, you'll probably be more cognizant of it. But we sold it to every person, pretty much, that got on a PowerPlate. So taking a step back, how did we do that? So if you're familiar with billing within a hospital or within a physician's office, ICD-10s are International Classification of Disease. What is that disease? What is the patient presenting with? There's over 3,000 codes for cancer, just so you know. CPT is a current procedural terminology. That's what we're doing to help that disease state. And HCPC codes, that's what's used in a hospital environment. So it's Hospital Common Procedure Coding System. So all three of these are how individuals get billed. I'm sure every one of your health systems has a billing department. After this presentation, you can show them this and maybe it'll create some conversation about how to get reimbursed for some of the things that you're already doing. So talking about patient-centered care, patient-centered benefits. You know, we know that CMS emphasizes a lot of patient-centered benefits, but it's usually in the form of compliance. It's not where the hospital or the health system gets reimbursed. We know with TPH, temperature, pressure, and humidity, within the ORs, there's requirements. But if we truly think about it, I loved how Nancy said the guests who come to your facilities, right? You're treating them where they want to be there. You're making that an environment that's really positive. Well, years ago when I was working on Cancer Treatment Centers of America, they weren't patients or families. They were guests that came in. It was a hotel mentality that we wanted them to feel that they were welcome. So whether it's CMS or maybe for service, what are we doing that can elevate that experience and get paid for it? So the quality measures we know, the patient safety we know, but what is currently happening? So these are the environmental codes within the hospital today. There's codes of participation that you can read, hazardous materials. Now these are codes for compliance, but can we flip them as an industry and make them codes for reimbursement? Okay, let's take a picture. And these are what CMS currently has. There's quality payment programs, hospital-based value programs. We know about HCAHPS, right, with patient satisfaction scores. That's a big deal, having patient comes, because that's value-based. But now if we really look at what is the patient going through, and just as we did within the power plate modality, how are they being affected by different specialties? So number one is identifying the need. What is the need for these patients? What are patients feeling maybe coming out of surgery? What's happening within, for me, was the lung environment, right? What was the air quality like in that area? Is there a need for that anxiety, for that patient to be in control of something? Is it a smart patient room? Is it just having control of something? So we know that the smart patient room allows a patient not only for education, personalized environment, monitor control, but how to affect the patient outcome. So looking at that, there's already a ton of third-party data out there. So that's the second step. Let's collect and analyze that data that we already have, and what's the gap? How do we justify to CMS that this needs to be paid for? Then it's the code development. CMS has a full panel of individuals that review codes. So the codes might already be there, which is what we found with a lot of the power plate modalities and the specialties, but we can also create codes for the reimbursement. Then we go through stakeholders. Same thing. I know this seems like a long process, but for reimbursement, it's worth it. If you can get paid for something that you're already doing, why are we not? So the stakeholders involved, and they bring in a number of different stakeholders. It's not only CFOs, it's also the physicians, it's the patients who are being affected by this. And the goal is to get patients healthier faster for the payer, for the hospital, for the families, and of course for the patient. So then once we realize that, look at, here are things that are happening in the hospital environment, these can be reimbursed, the coding committee reviews it, and then it gets published and added to the CMS coding, okay? Now, this is an extensive collaboration with a number of different groups and individuals, but it's really, if we get people together, like I work with payers, I work with health systems, I work with vendors, understanding everybody's relationship for the outcome and what they need to do, it can happen. And so that's what we're excited about. So where do we go from here? Do we look at what codes are there today? Because there's so many. Do we try and create new codes, which we can do, for what we offer within the healthcare facility, or do we just do status quo? And that's our options. That's it. Thank you. I'm on time. I know you're asking, so what questions do we have?
Hi, Dr. Ranajee.
Hi.
Do you feel there is a huge disconnect between C-suite, CEO administration, design, and doctors when it comes to the whole thing? Because if upper level administration, the CEO looks for how big the health system gets or how much money they make, or one system acquires another system versus patient care. Do you see there is a huge disconnect in the pyramid of the ESG?
Of ESG or in terms of billing or patient outcome? So is there a disconnect between the C-suite and with what's happening at the patient level is what you're asking? Yes and no. So I think there's different drivers in the C-suite, meaning you've got stakeholders and other individuals that you have to be responsible for. Patient care, because of value-based medicine today, it is more and more prevalent. Because of things that are coming with technology, the C-suite is definitely becoming more engaged. In the past, yes, it's M&A. All the health systems are coming together because of issues with COVID and financial burdens and what's happening today in the healthcare landscape. But as that gap closes, it's going to be beneficial for all the components, for, as I mentioned, the global, the health systems, and then the patients themselves. So I think that gap is getting smaller than it was in the past, absolutely. And now because we've got, we've got nonprofit health systems, and we have the systems that are with PE companies or that are owned by outside entities, you see a difference there as well, how that gap is closing, and the ESG components. Does that answer your question? Thank you. Anybody else?
You mentioned that there could potentially be codes that are already existing for some of the investments that we're doing. Yes. So you talked about air quality. So do you know of investment in HVAC systems that are tied to some kind of coding reimbursement?
So that's a great question. He asked, are there currently HVAC systems that are tied to codes today? So today the codes are primarily with compliance. That's where we would create a new code. With air quality, if we can justify looking at what's currently in the literature and the codes that are there today, there is for air quality. Yep. And we actually brought in CMS, other CMS experts to go through all the codes that that are available today and understand what areas we're going to look at. Okay. Anything else?
Anyone else? Anyone else? All right.
I know it's lunchtime.
Thank you so much, Dr. Ranajee.